Thank you. Well, good afternoon, everyone. My name is Dan Malone, and welcome to the fourth in our series of improving the relevance of drug-drug interaction warnings. Today, we're going to focus on a very interesting combination of medications, SSRIs or SNRIs, and thiazide diuretics. I'd like to tell you a little bit about our program before we get into the actual content of this particular interaction. So, I want to acknowledge our colleagues, my colleagues on this grant from various institutions across the country. We appreciate all the work that everybody's been doing on the project. So my name is Dan Malone, and I'm your webinar host for today. I'm a professor at the Department of Pharmacotherapy at the University of Utah. I'd like to provide just a quick overview of the project and also introduce our two speakers for today. So first, we want to mention conflicts of interest that displayed on this slide. By and large, we have no conflicts of interest, but Drs. Hansen and Horner, publishers of the textbooks and other documents related to drug-drug interactions. The work that we're presenting has been sponsored by the Agency for Healthcare Research and Quality under a grant from them. But the responsibility is solely ours and does not necessarily reflect the agency or its employees. So we're going to talk about drug-drug interactions today. We always kind of start with just a grounding of what a drug-drug interaction is. So it's a clinically meaningful alteration of the effect of one drug, and we typically call that the object drug as a result of a co-administration of another. We typically call the second drug a precipitant drug. However, sometimes when we look in the literature, we have to kind of extend that notion to what a drug-drug interaction is to what we call a potential drug-drug interaction. So this is where we think things might interact, but we're not sure. So what we'd like to do today is try to provide as much evidence for a DDI as compared to a potential drug-drug interaction. The main attributes of our project is to try to figure out how we can make our defenses more effective in preventing harm to the patient. So we know that when patients take two medications, there's a possibility that our defenses have holes in them, and we call this the Swiss cheese model. So when these holes line up is when patients get harmed. So when we lack some element of the defense is a potential for the patient to be harmed. So our goal with this particular project is to shrink the size of the holes. We know it's impossible at times to eliminate them, shrink the size of the holes, and also offer strategies to improve the way that we provide warnings for these particular medication safety issues. And one of the things that we try to do with this particular project is focus on potential risk factors that would help us identify which patients are at greatest risk. So what we'll do next is turn it over to Dr. Phil Hanston, who's a professor emeritus from the University of Washington. Dr. Hanston has been studying drug-drug interactions for longer than many of us have done it, and I could throw in a few other things about longer, but I won't. But Dr. Hanston is a worldwide expert in the area of drug interactions, and I'll turn the presentation over to him.
Okay, Dan, thank you very much. And yeah, thank you for stopping short of insulting my age. But I will say I have been studying drug interactions for 55 years. The first article I read was 55 years ago. So I've been doing it a long time. Of course, I was only in kindergarten when I started doing that. But today, and by the way, I hope everybody's doing well, given everything that's going on around the world. Today, I'd like to talk about a drug interaction that seems to be flying under the radar many times, that between thiazides and SSRIs. Hyponatremia, there are various levels, and we have adopted these four categories of normal, mild, moderate, and severe. These are generally what most people use. Some people have slightly different figures, but this is generally what people talk about when they talk the various levels of hyponatremia. Symptoms usually do match pretty well with this, but not always. Sometimes you can have somebody with moderate hyponatremia that has very severe symptoms, and another person with moderate hyponatremia that has very few symptoms at all. So it's in general matches the symptoms, but not always. Okay, next slide. As far as hyponatremia, well, first of all, let me just mention the main issue here, and that is that both SSRIs and SNRIs, and by the way, whenever I say SSRI, I'm implying both SSRIs and SNRIs, but both of those types of antidepressants and thiazides individually cause hyponatremia. And so it would just make sense that they're additive. They probably have different mechanisms. And in fact, that's what it looks like. So hyponatremia is the most common electrolyte disorder. And it's more in hospitalized patients and those in various ambulatory care facilities than it is out in the community dwelling population. This is one of the cases where the elderly clearly have a higher risk. It's a major risk factor for hyponatremia. And it contributes to things that we see in the elderly anyway, like cognitive disorders and falls. So, and as we'll talk about at the end of this, it may also contribute to all-cause mortality in the ambulatory elderly population, chronic hyponatremia. Okay, next slide. So different antidepressants, we know it's not depression itself that's the cause of this. They've looked at this pretty carefully, actually. And it's really just the SSRIs and the SNRIs that seem to be a problem as far as causing hyponatremia. This would lead one to believe that it has something to do with serotonin, which is likely. They're not really sure exactly what the mechanism is, but it probably does relate to serotonin reuptake. Tricyclics, mirtazapine, bupropion, not very high risk, and they've done epidemiologic studies to look at that. Now, when I say tricyclics, of course, keep in mind that clomipramine is an SNRI, so it's technically a tricyclic, but it really goes into the SNRI category. Okay, next slide. So the symptoms that one sees, there are asymptomatic people that have no symptoms at all or very subtle changes. Now, you might think this is something not to worry about, but as we'll talk at the end, people that have asymptomatic hyponatremia chronically may in fact have serious problems from that. It's not an acute problem, but more of a chronic issue. Then there's mild to moderate symptoms, confusion, lethargy, fatigue, weakness, etc. And they're very, most of these are non-specific. And since the elderly are the people who get this most often, this is a problem. I mean, I'm elderly and I've been confused and lethargic and irritable already today. So not really, but it is a problem because of these symptoms being so non-specific and some things that might attend the elderly anyway. So it's hard to make the diagnosis sometimes. It can be severe, where you get into severe disorientation, hallucinations, even seizures. And in rare cases, it's not common, but it actually can be fatal. Okay, next slide. Risk factors. Dan mentioned at the beginning that we try to focus on risk factors. This is one of those interactions where risk factors are critical. They're usually important for most drug interactions. Risk factors play a role. But for this particular combination of SSRIs and thiazides, it's even more important than usual. And especially this first group, age, gender, BMI. People 65 or older, females seem overrepresented, and also people that have a low or a very low body mass index. The next line down, salt restriction, high water intake, and for that matter, hot weather. People who are drinking a lot in hot weather, and they've actually shown that with heat waves that hyponatremia seems to be a little higher. People may be drinking lots of water with very little in the way of sodium in it. Running triathlons or marathons is that risk factor, so be careful if you do that. Then comorbidities, other diseases. There are a number of diseases that may increase the risk of hyponatremia. And so we assume, we don't have good data on these diseases in the presence of thiazides plus SSRIs, but one would assume that they would increase the risk. There are a number of drugs that have been associated with hyponatremia. I've listed some of those there. And it's not every member of the classes. For example, with antiepileptics, some drugs like carbamazepine seem to be much more likely to be associated with hyponatremia than others. And then finally, genomics, not too much here. The 2D6 doesn't matter. They've actually looked at that. So 2D6 is involved with CYP2D6 with some of the SSRIs, but it doesn't seem to make any difference there. But it can make a difference with the thiazide side of this interaction. And they have identified a variant, a genomic variant that seems to increase the risk of thiazide hyponatremia. And by the way, before I get off this slide, that comorbidities there, when we said low serum sodium, we're talking about a pre-existing low serum sodium. So if the person already has, and this makes sense, of course, that if they already have a low sodium to start with, and then you give them these drugs, SSRIs or thiazides, and especially the combination, that the risk would go up. Okay, next slide. Okay, so what is the evidence that we have? Logic would tell you that if you have two drugs that both cause hyponatremia, that putting them together would be more of a problem, but especially since they seem to have different mechanisms. But it's also been shown in a couple of epidemiological studies. This was a case control study, really primarily to look at the risk with SSRIs versus other antidepressants. And they had 107 patients receiving various kinds of antidepressants, SSRIs and others. And they had 29 people with hyponatremia and 78 without. And what they found was that it was primarily in the SSRI group that had the hyponatremia compared to other antidepressants. But on the next slide, you see they also looked at, this is from that same study, they looked at various combinations. In green, these people didn't receive SSRI or a thiazide. They were just getting some other antidepressant, which by definition here is a ratio of 1. Then the SSRI alone increased the risk, and we've known this dozens of studies showing that SSRIs alone increase the risk of hyponatremia. This is extraordinarily well-documented phenomenon. But look at what happens with adding a thiazide to that, a substantial increase in purple or whatever that color is. And then finally, SSRIs plus a thiazide plus elderly, the risk was even higher. So it does appear that the combination in the elderly has a pretty substantial risk of hyponatremia. Next slide. Here's another study which basically found the same thing. Different kind of a study. This was 199 patients, psychiatric patients. 74 of them received SSRIs or SNRIs. And in the controls, it was only 10% of them developed hyponatremia, but it was almost 40% in the people getting SSRIs or SNRIs. Now that's a little higher than most people have found, but it certainly does show that they're associated with that. And if these people, then when they looked at if you throw thiazides into the mix, the risk is even higher. So look at the bars over on the right, no SSRI or thiazide, 1 by definition. SSRIs alone, 5.7 odds ratio, and over 11 if you combine SSRIs plus thiazides. They didn't look at the age issue here, but if they had, I'm sure that the age would have added even another risk factor to this. Okay, next slide. And just a couple of case reports. We're going to summarize the 11 case reports that have been published in the literature, but here's just a couple of them to give you to drill down and see what happens in individual people. This is a 63-year-old female on chronic thiazides, admitted for depression. Now she had a normal sodium to start with. It was not low. They started her on the antidepressant duloxetine, and they titrated her up to 40 milligrams a day. And then 4 days later, she had a seizure and was unresponsive and an extremely low sodium level of 103. That's extraordinarily low sodium. And it happened fairly quickly in her case. And they had to treat her with hypertonic saline to get her sodium back up again. And the drug interaction probability scale that we use to rate these things, we rated this as probable. In other words, it was probably that the SSRI plus thiazides contributed to this reaction. Next slide. Here's another patient, this case much older, 81-year-old female on chronic thiazide and various other drugs. She was started on escitalopram. And in her case, it took a little bit longer. It's typical that it takes a couple of weeks. It can be just a few days in some people, or even months in others, but the typical case is around, say, 2 or 3 weeks. And she developed increasing confusion and recurrent falls. Now, in somebody who's 81 years old, this obviously is something that can result in, a fall can result in something that will eventually do them in. So not a good thing to have happen in an 81-year-old person. Her admission sodium was 120, and this was after she had received these drugs, the SSRI and the thiazide. They stopped everything and also gave her hypertonic saline, and she improved. So it had a happy outcome, but it could have been much worse. Again, the DIPS rating, we gave this a probable. Okay, the next slide. So just to summarize those cases, those 11 cases, the 2 that I just talked about, plus 9 others, the age range you can see on the older side, gender, mostly female. It was it doesn't matter which SSRI or SNRI the person gets. It's all sorts of agents have caused this. The onset in this case 12 days, but the range was 4 to 28, and the serum sodium mean was 116. And next slide. To continue the summary here, the signs and symptoms, confusion. Again, this is a problem because confusion is not uncommon in the elderly population. Same with fatigue and lethargy, the next most common. Headache, not very specific. So now some of the ones at the bottom there, hallucinations and delirium, you wouldn't normally expect to see. So you suspect something was wrong if those happen. But diagnosis, slow diagnosis of this is probably an issue. Risk factors, 8 of the 11 were 65 or older, and then some of them had other risk factors like ACEs and ARBs, low sodium to start with, and other things. And the DIPS rating for these 11 cases that we assigned, probable 9, possible 1. The unknown, they didn't provide enough information for us to really assess it. Okay, next slide. And we're getting down to the home stretch here. I want to talk about, so far we've been talking about acute hyponatremia, which can be serious, can even occasionally be fatal, but certainly can result in hospitalization, et cetera. Now we're going to talk about another type of problem with, sorry.
We seem to have lost our speaker for a moment. I'll wait till he gets back.
Dan, can you hear me?
Yeah, now we can. Yeah.
Okay, well, I don't know what happened to my screen, but I have the slides here printed out, so I'll just continue. If you can see the slide on the screen, we're good.
Yeah, we are good. So please continue.
Yeah. Okay. So what we have is this mild chronic hyponatremia, which probably, as far as total numbers, is more of a problem than the acute hyponatremia. And this was a retrospective chart review of 608 people in a home-based. So these people were at home, but it was a home-based primary care program. Elderly, mostly female, mostly African American, although that doesn't seem to be necessarily be a factor. Almost half of them were frail, and that is a factor. Frailty is, and there are definitions for frailty. I'm sure Dan could give them to you, but at least almost half of these people were frail. Now, initial hyponatremia, in other words, a point prevalence of hyponatremia was 8.7%. But this mean chronic hyponatremia, which is they defined as more than 6 months with repeated low serum sodium levels, was 4.1%. This mild chronic hyponatremia was associated with falls, fractures, hospitalizations. And when they looked at drug causes, not all of these people were getting thiazides and SSRIs alone or together, but when they looked at drug causes, they were the most common cause as far as drugs contributing to this problem. So they were clearly, in their view, contributing factors, the thiazides and SSRIs alone and together, to this chronic hyponatremia. Next slide. And it is the most, this mild chronic hyponatremia is the most common cause or the most common type of hyponatremia in outpatients. It's pretty common in nursing homes, 18% in one study. And over a 12-month period in this study, 53% had at least one episode of hyponatremia. And the problem with this, and not just from the studies cited here, but other studies as well, suggesting that this mild chronic hyponatremia is associated with confusion and other cognitive disturbances, gait problems, and falls. That's not good in elderly, as we've talked about. And also even all-cause mortality seems to go up with this problem. So it may be more insidious, less well documented probably, and less well appreciated than the acute hyponatremic syndromes that occur, but it may ultimately be a significant problem. Okay, next slide is a summary. It's the most common electrolyte disorder, hyponatremia, especially a problem in the elderly, as we've talked about. The findings are nonspecific, and that is a problem because it's hard for many people to be diagnosed. Thiazides and SSRIs individually increase the risk, and they do appear to be additive. And again, as I mentioned, this is something that you would just expect. So if they don't cause it by the same mechanism, which they probably don't, you would guess that they would be additive, and the epidemiological studies comport with that. Acute hyponatremia, which probably isn't as common, can be life-threatening, but the mild chronic hyponatremia is more common and probably overall causes more morbidity and mortality. So the final two slides, the next slide is the risk factors for hyponatremia, which you've already seen. This is just a repeat of the slide you saw at the beginning, risk factors for hyponatremia. I just wanted to quickly show that slide again, that there are these various risk factors, and go to the next slide, which is management. So I've divided this up, 65 or older on the left side and under 65 on the right. If you're 65 or older and you have major risk factors, in other words, female, you're frail, you have a low body mass index, you have a pre-existing low sodium or salt restriction, those are seem to be the most the most important major risk factors. If you have those two going on, you have a substantial risk, and you probably need to try to find alternatives if at all possible. If you go down, keeping in the 65 or older column, if you go down one and you have other risk factors, in other words, you don't have the major risk factors, but you have diseases or drugs or other things that are less well documented to increase the risk, it still would be reasonable to consider using alternatives to one or the other of the agents. But if they are used, you really ought to monitor the sodium and also monitor for symptoms. And then finally, in that left column, if you're 65 or older and you don't have any risk factors at all, you probably still have an increase in risk if you use both of these drugs, and probably worth monitoring the patient. Over on the right side, if you're under 65, but you do have major risk factors, again, you're probably at moderate risk in that case, because age is such an overriding, seems to be such an overriding risk factor for this. If you are under 65 and only have moderate, the other risk factors, the moderate ones, there's probably an increased risk worth monitoring. And then finally, if you're under 65 and don't have any risk factors at all, I toyed with the idea of making this one green, but I think, Dan, in the future, maybe we can make this beige or some other color. You're probably at the lowest risk of problems, but you're still at probably some increase in risk from it. So actually, the next slide is the final slide. So there is compelling evidence that both SSRIs and thiazides individually cause hyponatremia, and we need to be pretty careful about giving them together. The evidence of giving thiazides with SSRIs does in fact show that it increases the risk. This interaction has probably not received the attention it deserves given the frequency with which problems seem to occur with it. So we're in this process, we're trying to increase the awareness and hopefully reduce the adverse outcomes. Okay, that concludes my part, so I'll turn it back to Dan.
Thanks, Phil. Really appreciate that. So that's the first part of the presentation. We'd like to get a little bit of feedback from you all on perhaps why you're on the call with us today. So we're going to do a quick poll here. We didn't do this at the beginning, but we'd like you to give us a sense of what did you expect to gain from the webinar today? I recognize that you've had some of this information already, but we'd like to see why people are attending these particular webinars. So we'll leave this up for about another 15 seconds or so. We do appreciate people giving us a sense of why they joined our call today. Excellent, we appreciate that. Thank you very much. Okay, I think that'll be sufficient for now, Sheila. So, so gives you a sense, fairly broad distribution in terms of about 28% to increase clinical knowledge, 24% to reduce alert fatigue, 19% to ensure the organization's warnings are accurate, to learn more about the field of drug interactions, informatics, 28%, and then 2% other. So, all right, well, thank you very much. What we'd like to do next is discuss how we've been able to create an algorithm with respect to this particular interaction and test that in some both synthetic and actual data. And to do that, we have Rich Boyce, who's an associate professor with the Department of Biomedical Informatics at the University of Pittsburgh. Rich, you want to go ahead and take it over?
Thank you, Dan. Hello, everybody. So Phil did a great job of explaining the clinical rationale behind the algorithms that we developed. And one of the things we do is we try to validate the logic of the algorithms, and then we try to run it over real world data, some form of actual electronic health records data. And that's what I'm going to describe today. Once that's all done, we've released the code that we've written out publicly to folks. So can you go to the next slide, please? This is an overview of how we tested the algorithm for SSRIs, SNRI Thiazide diuretic drug interactions. Starting from the left-hand side, we have two different sets of data that we worked with. One we call synthetic data. The purpose of the synthetic data, this is where we just make up patients and we put it into a data set that we can run the rule over or the algorithm over. And the reason we do this is because we want to check the different branches of the rules, and we want to make sure that if we use the, for example, coded drug data, conditions and labs that are available in the electronic health record, are we able to actually trigger the different branches of the rule? And then underneath the synthetic data, you say, well, we're also loading real world EHR data, and I'll describe that data set in a minute. In both cases, we're putting it into something called a common data model, or a CDM. The OHDSI stands for Observational Health Data Science and Informatics. Some people are more familiar with it as OMOP or OMOP. It's a common data model that's very widely used, and you can look below the database icon or symbol, and you'll see the tables as boxes within the data model square down below there. So we have the data loaded into different tables for the person, measurement, drug exposure, visits, and then there's a standard vocabulary which would have things like your drug codes and RX norm, and your condition codes in ICD-9 and so forth. So we loaded the synthetic data and the real world data into two different databases, both using the same data model. And then towards the right, we implemented the algorithm that you heard Phil talk about as a logical rule that was ran in a system called Drools. And some people who work in decision support will be familiar with that. It's been around a while. And we run it against those two different data sets. And what comes out is essentially in a table form, but we convert it to something that looks a little nicer, is the different synthetic or real world patients that land in the different categories that Phil has mentioned. Can you go to the next slide, please? Thank you. So this shows our testing of the synthetic, using the synthetic data. There were several different branches of the rule that we tested. So we would create a synthetic patient for each of those branches. So there's just the simple concomitant exposure. And then there's the case where the sodium levels are below the threshold. And then the third item would be the sodium is above that threshold, but the person's over 65. And you can go down through the next three categories and see we're just bringing in then drug or condition risk factors. And so we were able to, with the synthetic patients, test every branch of the rule and confirm that the way that we coded the drugs and the measurements and so forth for risk factors actually functions. Can we go to the next slide, please? Okay, for the real world data, we used extract of data from the University of Arizona, I should say Arizona up there, sorry, for a university medical center. The data was extracted in 2018. And in the data request, we asked for patient diagnosis and drug orders and lab results. This is for a total of about 9,000 patients. You can see the exact number on the slide. And we're not going to show a lot of demographics on this real world data set here. You can check with us for further details, but the average age was 44 years old. Next slide, please. And this is the results of running the rules over that 6-month sample. By the way, I should mention this is all inpatient in the sample that we ran it over. And starting from the top would be, on the left-hand side, people who, based on the lab values, are below the threshold. You'll see that we didn't find any cases in that 6-month sample. And so if we go further down, we go to the next decision point. Again, looking on the, I might have said right the last time, I apologize. On the left-hand side, we had 62 cases where the person was over 65. And then if we continue to go down, you can see that the risk factors and the condition factors showed up in relatively small numbers. Now, part of the point of this slide is to show that if you had a system that was just triggering an alert based on the concomitant exposure to the SSRI thiazide, it wasn't taking into consideration the actual lab values, the person's age, and conditions or other drugs that are of relevance, then, if we count all these up here, that's 62 plus 5 plus 4, so like 71 alerts would have triggered with no classification. But in this case, there could be some filtering that would be done by the system, depending on if you needed to do interruptive alerts with like orange and above, you would at least have 9 fewer alerts that were fired over that time period. So that's part of the point of this, is to show the contextualization and ideally, hopefully, a greater specificity and contextualization of the alert. Next slide, please. Thank you. So there's not obviously a lot of time on the call to go into the details. We want to refer you to the link that's showing up on this slide, where you find a nice rationale that's written by one of our team members. If you have a hard time getting that link, just go to ddicds.org and go to drug-drug interaction algorithms, and you'll see a link which will take you to this page. So there's a nice description of the clinical evidence that Phil described, and also, next slide, please. This, if you scroll towards the bottom of that page, you're going to find a lot of documentation that you can download. There's an in-depth analysis that was written by Dr. Hanston, and then all the artifacts that we created to test with the synthetic data. And also, we have implemented these rules in clinical quality language, CQL, which ideally makes them shareable. And we have the value sets also that we used. And what I mean by a value set, I think, is explained on the next slide for those folks who aren't so familiar with it. Oh, okay. So first I'll explain a little more about the CQL. So again, in our testing and framework, originally we used rules, but then we've migrated now and we provide these artifacts up there. So, and the reason is because HL7's formed a standard called clinical quality language. And its intention is to allow different organizations to run these rules if their data is available in the Fast Healthcare Interoperability Resources standard, or FHIR. And so you can go see our rules. They're written in CQL, and they're able to run over FHIR. And can you go to the next slide, please? Now, rules is what we used to test things originally. And there's for folks who are familiar, want to play around with this, you can download a Docker container. A Docker container is something that you can deploy. It's a virtual sort of environment that you can run, and it'll allow you to rerun what we did, so you can see the experiment that we ran. And also, in principle, you can point it to your own OMOP or Odyssey formatted common data model data set and run the rules to find out how it runs on your data. Next slide, please. In terms of value sets, these are, folks may not be so familiar with those. A lot of times the interactions are written in, like, for example, we hear SSRI and Thiazide diuretics. Well, what does that actually mean? Well, we need a list of codes and some terminology that is being used when the drug orders are being stored in the electronic health record. And that's called a value set. Some people call it a concept set. And you can see on the picture there, what it does is it allows you to organize those codes from different systems. Like in our case, we're primarily organizing it around RX norm for the drugs, and SNOMED or ICD-10 for the conditions, and LOINC for the measurements. Next slide, please. So if you want to view those, one of the things you might stumble upon if you go through our website is a login page that looks like this. That's because some of these terminologies are sort of protected. So like SNOMED, for example, is free to folks in the United States, but not necessarily everyone in the world. So you have to get a UMLS account. It's free. But once you have that account, you're allowed to log into this value set authority center, and you can see and download the value sets that we've created. Next slide, please. Thank you. And if you go through that process, this is an example of what you'll see. So that's sort of been a value set for the SSRIs that we put together. Notice that these are at the clinical drug level, very specific with the quantity and formulation and dose form. And these are extensional value sets, which means that we listed everything. So they will kind of go stale over time if we don't update them. So just be aware of that. For example, check the date on the version when we send these out. You can see it's 2019. So if additional SSRI codes have been added since then, they may not be present in this value set. Next slide, please.
Well, Rich, that's kind of the conclusion of your slides.
Okay, perfect. Thank you.
Yep, and thanks for that. We did take a look at various compendia and other sources to see how they classified some of this interaction with antidepressants and thiazide diuretics. And keeping in mind that I guess I'll put a disclaimer here that we didn't actually go to the source. We didn't contact companies to find out how they actually classified it. We had individuals who had access to these various compendia within their organizations to run some tests. So there may have been some filtering happening, but this is, I guess, to illustrate that there's perhaps a little bit of heterogeneity across the different compendia with respect to this particular drug combination. So some organizations classifying it as no interaction or not flagging as an interaction, others indicating it up to a moderate level. So perhaps there might be some opportunity to get consistency here with respect to this particular interaction. We do want to get some more information from you, if you don't mind, through a couple other polls. One of the purposes of our project is to help organizations reduce alert fatigue and take the information we're using or we're developing and use it in their organization. So the materials that Rich just presented, we provide free of charge and available for any organization to implement. We know that there's a lot of challenges with implementing something like this in an organization. So if we can have our next poll, Sheila, we're interested in if you were to attempt to use this information, so what would be the most significant barrier if you wanted to implement this particular algorithm within your organization? So we recognize some of you may not be in a position to use this information within your organization, but you could give us a sense of what are some of the barriers that make it challenging to use the data that we're trying to provide to you and the artifacts. Once we get to about 60% of our attendees voting on this, we'll probably close it down. We have 83 people that have joined today, and we got responses from about 50 at this point in time. All right, so why don't we go ahead and stop the poll, Sheila, and share that. 17%, the lack of functionality within the organization's EHR. Programming support, yeah, that's always a challenge. Attaining authorization, yeah. So if you don't mind putting in the chat, if there's any way we could perhaps help you overcome these barriers, you can chat privately to the panelists, or you could also send it out for everyone to see. I see a couple comments there. Issues with modifying the existing databases is one of the issues. So if you could just provide a couple issues in terms of implementing algorithms like this, that would be useful for us to know about. So change the way that perhaps how we do things. So thank you for that. Okay, well, I'm going to just say that our grant is intended to try to help organizations, and hopefully some of our tools will save you time and reduce alert fatigue, and hopefully give you evidence-based recommendations on how to improve warnings with respect to drug-drug interactions. You can reach me or Rich at our emails here, or you can contact us via our info link on our website at DDI-CDS. And just as a final reminder, our project is sponsored by the HRQ, Agency for Healthcare Research Quality, by a grant, but again, it does not necessarily reflect their views or the views of anyone in the agency. I want to thank Rich and Phil for their presentations today. Thank you very much, gentlemen. I appreciate all the work that they've done on this project and others within the grant. So we have one last question before we sign off. So so if you could tell us a little bit about how we can improve our webinars, we would appreciate that. So before you leave us today. And after you voted, if you wouldn't mind also just chatting how you heard about our webinar. It's just something I just thought about. That we have a fairly broad audience, I think. Some of you are learning about it because you've attended previous ones, but if you're finding out about our webinars via bulletin boards or something along those lines, we appreciate that information. And we do post with Amy we have been trying to post via other organizations as well. Yeah. Well, with that, we'll go ahead and wrap up. If you have any questions, feel free to chat them. We'll try to answer those in live time. So thanks for responding. I'm just looking at the responses here to see if we have any particular questions that we can address while we're on the call. We do make the webinars available via our website, so you can have individuals view this particular webinar after the fact. It takes us about 3 to 4 days to get those up. So, and we encourage you to send your colleagues to our website to view these materials. Okay, I'm looking to see if we have any other questions that we. So the question is, do the same interaction exist with loop diuretics? So Phil, do you want to address that question?
Yes, it does not. Interestingly, does not. And am I still coming through okay? Is my volume okay?
Yeah, yeah.
Okay.
I can hear you fine.
Yeah, interestingly, no. And even to the point where loop diuretics are sometimes used to treat hyponatremia. So it does not appear to be a problem with loop diuretics, and they've actually looked at it.
Thank you for that. So, right, I'm just looking to see if there's any other questions. Getting a fair number of chats with respect to the questions I was asking the audience. So, just looking to see if there's anything that's relevant to the audience. I don't see anything. Any final, I guess just a last chance here for any further clinical or informatics questions. Yeah, we are looking for successful or organizations to partner with to implement these. So if you're interested in implementing our rules, feel free to reach out to us and we'll try to support you in doing that process. As mentioned earlier, we try to provide the clinical documentation to why we think our algorithm is useful, as well as the artifacts and the tools that could be used to implement these. So with this, I think we'll end it. So thank you very much for your attendance today. Have a great day, and we look forward to seeing you again on one of our future webinars.